Welcome back. What if you woke up one day and nothing felt real? Or perhaps you looked in the mirror and felt even though you recognized yourself, you didn't seem real in some sense. Or you felt disconnected from yourself, as though you were just running on autopilot. These experiences are more common than you might think. In fact, they are part of an increasingly recognized phenomena known in the psychological community as depersonalization and derealisation. With us today to discuss these experiences is Dr. Elaine Hunter. Elaine is a consultant clinical psychologist who has worked with depersonalization and derealisation since 1999. She has also conducted research into improving the psychological treatment of this condition, and she developed a cognitive behavior approach for depersonalization and derealisation. In March 2019, she set up the Depersonalisation Clinic to give her the freedom to see a wider range of clients, and she's one of the founders of Unreal, a charity dedicated to raising awareness of derealisation and depersonalization and improving access to treatment and increasing research funding. Today we discuss why this condition has been so historically under-recognized, both in clinical settings and in public discourse, some common misconceptions about derealisation and depersonalization she'd like to dispel, common causes and triggers, how her clinic approaches the treatment of this condition, why derealisation and depersonalization may have an adaptive function in some individuals, how her understanding of this condition has evolved over time, and much more. This is The Thinking Mind, a podcast all about psychiatry, psychology, psychotherapy, and related topics. If you'd like to support us, do leave us a rating, a review, follow or subscribe on whatever platform you're listening on. And if you feel so inclined, you can also share it with a friend. If you'd like to support us even further, you can check out some of the links and services we offer in the description. As always, thank you for listening. And now here's today's conversation with Dr. Elaine Hunter. Elaine, thank you so much for joining me. What drew you to work with patients with depersonalization and derealisation?
Yeah, that's a really good starting question. Actually, my before I went into a clinical role, I actually did a PhD, and my PhD was in childhood trauma, a very severe childhood trauma. And during that research, in talking to people about their memories of their trauma, they started describing dissociative experiences. So they talked about dissociation that might happen spontaneously, sometimes dissociation that they consciously decided to use as a way of sort of mentally escaping from what was happening to them. And that really fascinated me. It was a little bit unexpected in the PhD. I was looking at memory, and then people were talking about dissociation. And so when I finished my PhD and I was looking for a kind of postdoctoral position, it just coincided with the depersonalisation, derealisation research unit, as it was then, being set up at the Institute of Psychiatry. So I kind of thought, oh, that sounds really interesting, and applied and then ended up working there. And so that's how I got into it initially, and then started looking more at dissociation.
And is there a lot of overlap between dissociation and derealisation, depersonalization? Are they, in your view, like distinct phenomena? Is there a grey area in between?
Yeah, again, a really good question. Generally, they overlap enormously. A long time ago, we kind of dissected the kind of overlap, and we found out that about 75% of people will have both depersonalization and derealisation. There were about 20% that had depersonalization only, and about 5% with derealisation. But actually, I am finding a few more people with just the derealisation only. But often, so technically, there are two separate things, and that probably leads on to the next question about what are the symptoms. Technically, they are two distinct things, and people can have one or the other. But as in the latest iteration of the DSM, the American Diagnostic Manual, they've actually pulled them together now. So they tend to be called depersonalisation-derealisation disorder. So they've kind of recognised that and merged them together.
And you were totally right about what my next question is going to be. My next question is, what are the symptoms and signs that someone is experiencing something like derealization, depersonalization? I would say from the outset, this is going to be on the rarer side of things. So I imagine it's something, you could correct me if I'm wrong, that a lot of people might experience idiosyncratically without ever realizing they have a kind of diagnosable condition. What are the signs of this condition?
So the key thing that makes it distinct from any other kind of condition is this sense of unreality, and disconnection from the world. So the unreality is that sometimes for the depersonalisation, so that's the bit that relates to the person, and derealisation is referring to the outside world. And as I say, usually the two are interacting with each other. But it's a sense that there's something not real about the person themselves. They don't really feel real, like they properly exist. And the outside world can seem unreal, like a stage set. So that's one aspect of it. It's actually got quite a few different essential criteria. So one is this sense of unreality. The other thing that people quite often describe is a sense of disconnection. So they may be disconnected from parts of themselves. So if you look at the kind of diagnostic criteria for dissociation, it talks about how all these functions that are normally integrated, like a sense of self and memory, an identity and a sense of reality, are all kind of are usually connected and integrated with each other. But sometimes things can feel disconnected, unconnected from each other. And emotions as well is another one. So people can feel like they're disconnected from their emotions. So people can also feel a bit sort of removed from their own body as well. So unreality, sense of disconnection, feeling like things are a bit dreamlike is another key one. So sometimes people will say that they don't really feel like they're really in the world. They're sort of not really in reality. They kind of feel like everything feels really dreamlike, and a loss of kind of consequences of their actions. So those are what I would say are the essential criteria that make depersonalisation and derealisation, that distinguish it from any other disorder. And those are very common, but in a transient state. So people will often have just momentary times where they might feel a bit spaced out, a bit disconnected, with lots of very common benign triggers to that. But for people that have the disorder, that has become much more problematic, associated with distress. It's sort of reoccurring and or constant. So it's a very, very common symptom. But also I would argue that the disorder is a lot more common than is previously thought. So I want to scrub out that rare. When you said that, I wrote that down. I wanted to come back to it because it's not as rare as people think. When you do the kind of epidemiological surveys, it's surprisingly common.
Excellent. Well, one of the things this podcast is for me to be proven wrong. So very happy to be corrected. So you're saying derealization, depersonalization, there are these experiences of unreality. The experience itself is very common in a limited way and can have various benign causes, which I'd be interested in. But to have the disorder, it's the same problem, but happening in a more constant, pervasive way. Is there a sort of determined set of time you have to be experiencing this to meet the criteria for the diagnosis?
Yes, so it can be that it's coming in episodes. So you can have an episode. So and that can vary, but it's more that it's associated with distress and impaired functioning as well. So and different, there's different diagnostic criteria, but generally it's going to be, coming for significant periods of time. But then there's some people that are also experiencing it chronically, but that can vary in intensity. So, they may have it all the time, but it may go down to 10%, or it might go up to, fluctuating up to, 90%. So those are things when I'm assessing people, I'm also looking at the pattern of their depersonalization, derealization.
I am curious to know how common it is. And I'm also wondering, is part of the reason that it's perceived as rare, is that because it's underreported? Because as I said before, I would imagine that it's the kind of phenomena, this sense of unreality, that if you experience it, you might not automatically think you're suffering from a mental health condition. I imagine a lot of people might think that they're having a spiritual experience or something along those lines. But again, you could correct me if I'm wrong about that.
Potentially, but people that interpret the symptoms in that way usually aren't distressed about it.
Yes, that makes sense.
Whereas people that are distressed about it are interpreting those symptoms in a fearful way.
And can these symptoms ever be brought on by a spiritual practice, such as meditation or even going on a silent retreat? And that kind of sense of being continually alone with your mind and your psychological reality for a long time, inducing that kind of experience?
As a scientist, I have to say, yes, that is possible. But I would really want to emphasize how incredibly unusual that would be.
Okay.
So I don't want people kind of thinking, oh, I can't do meditation or I can't go on a retreat, because I would, when we talk a bit later on about some of the common triggers, I don't know if I've ever heard that.
Okay.
Or if somebody has attributed, I can think of one person in literally 1,000+ people that I've kind of assessed. So, it's a very tiny percentage. But actually they were also experiencing lots of other difficulties at the time, which kind of made them go on a very intense retreat. So it's kind of like, was it that they were leading to that anyway, rather than the retreat itself? So, there is somebody who's done some work about how, just warning of some of the dangers of retreats and meditation, etc. But I think they're talking about people that are doing quite extreme versions of that. So it's not a trigger that I see commonly in the clinic at all.
Okay. So how common is the disorder?
So the disorder in normal populations, when I say that, non-clinical populations, I'm meaning. So we've done 2 reviews of surveys that have been done in kind of community samples to see how common the disorder is. And one was done a long time ago and one was recently updated, and both have been published. And this sort of magical 1% seems to come out. So this is a clinically significant level of symptoms. 1% of people, when you go into the community and ask people about these experiences and ask them about, how much they're having them, how distressed, how impaired they are, 1% of the population is experiencing it, which is really surprising. That is the sort of same level as something like OCD, the same level as sort of schizophrenia. I don't particularly like that terminology, but that's the kind of same level. And that's been done, through repeated surveys and actually globally. So the last review, we were looking at different epidemiological surveys around the world. Now, when you move into clinical populations where people have, anxiety, depression, or something else that's already causing distress, those numbers go up a lot higher. And then when you look at something like panic, the numbers are up in the kind of 80%.
Oh, so it's very commonly associated with panic attacks?
Very, very commonly associated with panic. In fact, if you know your panic diagnosis, you'll know that depersonalisation and derealisation are 2 of the symptoms of a panic attack.
Yeah, and I was just thinking it's kind of a chicken and egg problem, because I can imagine panic inducing a derealization, depersonalization experience. I can also imagine such experiences causing significant anxiety and panic.
Yeah, and that's exactly where I kind of started to, develop the kind of what is now the kind of CBT model of depersonalization, derealization. It's kind of, was really seeing panic attacks coming up again and again and again. understanding, well, there are some people where they'll have a panic attack. They might experience the depersonalisation, derealisation as part of their symptom cluster of a panic attack. But as the panic starts to subside, those symptoms dissipate. So, they go back to, how they were before. But with some people, they will then maintain some level of depersonalisation, derealisation. So part of what I needed to understand and explain was why that might happen. And it's almost like the anxiety about those symptoms then becomes a perpetuating factor, and it kind of keeps fueling the fear for this. So it's like the anxiety then attaches to those symptoms, and and then the anxiety kind of keeps the problem going.
And it becomes a positive feedback loop.
Exactly. So you end up with this kind of vicious cycle where, so sometimes people will say they still have panic attacks, but sometimes people will say, no, the panic, I don't have panic now, I just have depersonalisation, derealisation. But it's like the anxiety about the other physical symptoms of panic and anxiety has now landed on these depersonalisation, derealisation symptoms, and they're very frightened of them. There's often a lot of anxiety and distress about these symptoms, which is completely understandable because they do seem very frightening if you don't know what they are.
And again, I'm hung up on this question for some reason. I'm imagining someone experiencing this for the first time. Do people in your experience know what to do? Do they tend to go to A&E? Do they tend to go to their GPs? Are people familiar enough with these terms now that they might Google it and find professionals such as yourself? Do people have to take a long circuitous route to kind of finding the right diagnosis and the right treatment?
Yes, to all of the above, really. It's a lot better than it used to be, because I started working in this area about 25 years ago. And at that point, there was almost no information about it. So people had no initial awareness, or if they did experience symptoms, there was no way of getting information about what the symptoms were. Whereas nowadays, people can Google the symptoms and, get information about what these symptoms mean. So if you typed in something, I haven't done it myself, but if you type in something like, not feeling real or the world not feeling real, it will just pop up immediately with, what this is. The next step of trying to then get help for it is still a bit problematic. And although we've been working on that for, the same number of decades, and again, I do think it's a lot better. So I do hear people now that, go to their GPs, and the GPs immediately know what they're talking about and are able to help them. And, similarly, other mental health professionals, they're able to kind of go and get help. That is much better, but it's still very, very patchy, unfortunately. So we're really pushing always to try and raise awareness. That's why I'm talking to you today.
And what are the common triggers and causes for this condition?
Well, that's really developed over the time that I've been working with it, because initially, as I say, my background was in trauma. And so I came in thinking, there'll be lots and lots of people that will have had traumatic experiences, and that's how they've developed these symptoms. And then I was very puzzled that I wasn't seeing people with traumatic histories in the Depersonalisation Research Clinic. I was seeing people usually that had a lot of anxiety problems. So just going back to the trauma, people can have trauma, and trauma is a really big trigger for dissociation. I mean, there's plenty of clinical and research evidence for that. They will tend to then go off because they'll know that they've had trauma, and they'll tend to go off to seek help, and they'll disclose that they've had trauma, and they'll go off to trauma clinics and get trauma treatment. So it's not that isn't a trigger, but there are a lot of people, and so one of the misperceptions is that it's got to be trauma related. And actually, going back to what I was saying earlier about the strong association with panic, and how depersonalization and derealization are two of the symptoms, can be, of a panic attack. There's a really strong association between these experiences and extreme anxiety. So one of the big areas is people that have had sometimes a long history of anxiety that's just accumulated and just grown over time. So they might have had, sort of childhood anxiety, and then they've developed more and more anxiety, maybe leading into panic attacks. But it can be other types of anxiety as well, just very high levels of anxiety, and they start becoming really overwhelmed, and then they start disconnecting from the anxiety. Or somebody who, is experiencing a panic attack, and then, that very acute level of anxiety, they suddenly start feeling really unreal. So that's so we've got trauma and anxiety. The other two, there's two other main categories. Another one that I see a lot of is people that attribute it to some sort of substance use, usually recreational substance use, where they'll kind of say that, in the context of taking substances, sometimes one, sometimes they might have taken a few substances, they have a really horrible experience under drugs. And in the context of that sort of bad trip kind of experience, they might also feel some depersonalization, some derealization, but critically, they usually have a panic attack at the same time. In that kind of bad trip experience, when you really assess it carefully, they've often kind of then describe, feeling really panicky, really out of control. And I would say that's the common denominator. So they will then sometimes think, oh, it's the drugs, but the drugs then wear off, that they're then having this, really fearful kind of reminders of this experience. And again, that's anxiety has then attached itself to this kind of sense of unreality. And then they're kind of checking in, oh, am I still having that weird sort of sense of not being here, not being real, things looking weird, feeling out of my body a bit. And then that sort of starts snowballing from there.
And when you mentioned drugs, the first drug I thought of was ketamine, where the effect of the drug itself, ketamine, is a dissociative. And really the drug, the effect that the drug tends to have sounds a lot like derealization, depersonalization to me. So is ketamine a very common trigger in terms of drugs?
You're right, because ketamine has actually been used experimentally to induce the symptoms of depersonalization, derealization. So you're absolutely right. But sometimes, I think people that are taking ketamine will kind of then know this is what I'm expecting from the ketamine. So it's
a feature, not a bug, and that's a situation.
Exactly. So it's always, a bad drug experience. So, and what's really crucial is that, when I'm carefully assessing people, I'm keeping my, I'm looking to see, have they taken those drugs before? And often people have taken the drugs, before and it's been absolutely fine. And then suddenly they have a bad experience. So there's usually other factors involved. So I'm probably unusual, but I feel it's because I've really looked at this in a lot of detail in hundreds and hundreds of assessments, is that people usually will come in and feeling really like, oh my God, why did I do those drugs? And it's really caused this problem. And I do a very careful assessment so that I can often then say to them, can you see actually it probably wasn't the drugs. You've taken the drugs before, you were fine before, but this time you took them for certain, other reasons. You had a really bad experience on the drugs. You had a panic attack. This kind of then caused it to snowball, and that you're probably unfairly blaming yourself for taking the drugs, or blaming the drugs themselves in some way. And I say that because I think people can really get caught up in that, and it affects sometimes their help seeking, because they kind of feel like, I don't want to go and talk to someone about it, because they'll just say, well, why did you take these drugs? But also it's really important to kind of see that there are, there are other causes, and usually it's the anxiety or the panic attack or the bad experience that they've then developed almost like a kind of PTSD reaction to that bad drug experience, and then have become, phobic almost of these depersonalization, derealization symptoms.
I really like that you make that distinction, because I think when it comes to recreational drugs, especially I think psychedelics, cannabis among adolescents, parents, there's often this fear that like one instance of drug use can kind of change your brain in some irrevocable way and you're forever changed. And there's probably small amounts of cases where, psychosis might happen, although in all likelihood, they would have had a genetic predisposition for that. Generally speaking, this is really rare. It's very uncommon to see a single instance of drug use or even a few instances like changing someone at a biological level. What you're saying is actually it catalyzed something that is now persisting more at the psychological level in terms of inducing anxiety inducing the sense of unreality and that positive feedback loop we described earlier.
Yes. Well, of course, I'm biased to being a psychologist, so I will, obviously be promoting a psychological explanation for it. But also, actually for about 8 years in my career, I worked for a specialist CBT for psychosis service. So I worked exclusively with psychosis for about eight years. And I know that actually, again, that kind of our drugs a trigger for psychosis, and generally people will say, it needs to be certain circumstances, very young taking of drugs, and lots, very large amounts, and again, so I think there is now sort of evidence, but it's not usually a sort of one-off, and I don't know of any evidence for any brain level change from something like a one-off episode of taking cannabis. So people often fear that, and so it's a really common thing that I will encounter with people that attribute the onset to their symptoms to drug use, that I've damaged my brain in some way. And because the symptoms can be very frightening, can seem really unusual, people often kind of really frightened about what they mean. They often feel like they've kind of lost touch with reality. Isn't this what going mad is? Is this what schizophrenia is? Isn't that, losing touch with reality? So you can imagine what that would feel like, especially as you're saying, for a teenager that's kind of suddenly thinking, oh my God, I've damaged my brain in some way, or I'm developing psychosis. What am I going to do? Maybe I, just try and sit this out, hope it gets better. But, they actually then maybe don't seek help to get actually a different take on it and actually be reassured by that. And so sadly, I have heard quite a few people that, have literally gone for years of their teenager years just not ever telling anyone because they were frightened about how people would react.
And do we have any idea of what might be happening at the neurobiological level when someone is having an experience like this?
I mean, I'm probably not the best person to ask. I mean, I have worked with lots of teams of psychiatrists that have looked at this. And so you might be better off talking to somebody else but I mean, my take on it is that usually they haven't been able to find anything very substantial. So when the Depersonalisation Research Unit was first set up, there was an MRI scanner that had just arrived at the Institute of Psychiatry. So everyone was routinely getting MRIs and having a look at structural and functional MRIs. And basically they weren't able to really find anything at all.
Yeah, which is very common in all sorts of conditions, of course.
Yes. So, we could kind of then say, well, we can't find anything at a kind of brain structural or brain functional level.
I would be curious if, again, it induced any kind of effects, maybe similar to meditative experiences, something to do with the default network, perhaps the reticular activation system, but that's just my totally uneducated speculation at this point. Once someone's at the clinic, they've had an assessment and it's pretty clear this is what's going on. They're experiencing depersonalization, derealization. How do we start to think about treatment?
Yeah, so I usually start with a pretty thorough assessment, actually. I will go into quite a lot about the onset, but I also, because of my background in particularly childhood trauma, I will also want to get a very thorough assessment of all their kind of childhood experiences and everything that's led up to that, because that's often where some of the threads might be kind of leading back to. And then you can really start to put together a sort of shared formulation and a shared understanding, so people can kind of see what has led to these symptoms starting.
What are the most crucial things you're looking out for in an assessment?
So I would be looking for, childhood trauma or childhood adversity that might be leading someone to kind of feel, often with anxiety, but also kind of, being in a stressful situation. So maybe, it's sort of childhood adversity, like, parents arguing, etc., just so that is understandable about how they might have reacted as a child. So sometimes people will be able to kind of say, do you know what, I remember having this as a child very occasionally, but just very transiently. So sometimes you can find that there are early experiences before it became problematic. But I would say that's generally not the case. Most people have not experienced it. But usually I'm looking out for different psychological vulnerabilities from their life experiences. And also just getting a sense of their personality and their character before, again, these symptoms started. But certainly childhood anxiety I will be looking out for. I also haven't mentioned depression, because depression will kind of feed depersonalization and derealization. I would say it's less of a kind of obvious trigger, but certainly it can be a trigger in some cases. So as one client that I assessed described it in a very eloquent way, she kind of said, I was really depressed and I just didn't want to be me anymore. And so she kind of like disconnected from her sense of self. And you could kind of see that the depression can also lead to this sort of disconnection from self and the world. Perhaps, and we know that depression and anxiety are very closely, it's hard to have one without the other.
And I was curious as well, is there any evidence that psychiatric drugs can induce derealization, depersonalization, like antidepressants, antipsychotics, mood stabilizers?
Yeah, I wouldn't say that they kind of induce it. I mean, I wouldn't say that is generally a trigger, because we always need to think, well, why is that person taking the antidepressant or the medication? So there's usually something that's led to them taking this. But certainly some antidepressants will, that's what they're there for, will muffle those extreme emotions. So I was literally talking to a client yesterday who's on an antidepressant and quite a high dose of it. And she was put on that because she had, very high levels of anxiety, was really struggling to function, and also depersonalization, derealization. And it was to help minimize those negative emotions. But she's now recognizing at this high level of antidepressant that she can't also experience positive things. She's just started her first ever job and she kind of wanted to feel kind of excited about it, and realize, actually, can't feel excitement. I feel disconnected from it. So yeah, I mean, so at that level, they're kind of modifying the peaks of emotions, both sort of positive and negative. That's what they're doing, their job in that. But I wouldn't say that they would so it can make someone feel a little bit numbed from their extreme emotions, but I wouldn't say it's really triggering this very kind of strong, profound disconnection from themselves. As a general rule, again, it is a possibility, but usually people are being put, I'm always a little bit, people have been put on those for a reason. And if you track, I'm a bit obsessive about, chronology of people's histories and, being a sort of detective in that and kind of thinking, well, look, that's why that happened. And then that happened. And then that happened. And really trying to piece the chronology together, because I think detective wise, that really helps in working out what came first.
But so just before we dive into treatment, I am curious as well if any medical conditions need to be excluded. Anecdotally, I've heard low testosterone actually can cause people to see the world in quite a flat, uninteresting, two-dimensional way. Perhaps some overlap there. I'm thinking about thyroid problems as well. These kinds of things are going to present with physical problems as well. So if someone's low on testosterone, they might have low libido, say, low energy. Similarly, someone with a thyroid issue would have low energy, a lot of appetite, sleeping more, all sorts of physical symptoms. But do you see this much? Do you ever have to get the GP on board, do some blood tests, make sure there isn't anything physical going on?
The people that I'm seeing will have already been through all that process. So yes, so no, I haven't seen anyone with those. Similarly, things like, some types of epilepsy, or, if it's kind of caused by something that is quite transient and temporary. So someone may go to see their GP and it's, they will do some watchful waiting, okay, this is what this is. Let's see, you're in a difficult situation at the moment. Let's see how that pans out. And actually that may just alleviate it. So usually I'm seeing people when it has become a disorder and it's actually become a bit more, entrenched and problematic.
And so how do we begin to help people disentangle these problems and deal with them in a more manageable way?
Yeah, so after the assessment, as I start to kind of move into treatment, there's then a sort of phase of more detailed assessment to just really kind of start to see what is causing their fluctuation. So one of the first things that I'll usually do with just about everyone, actually, unless they really, really don't want to do it, is actually get them to keep quite a detailed diary. It's just a one-off, but just a detailed diary to look at what kind of things might be causing some fluctuations in symptoms. So if people are saying, well, I think they go from about 30% to 70%, we want to kind of see what's triggering the peaks. So I'll get people usually for a week or maybe 2 weeks to just track the sort of percentage of symptoms and what they're doing, so that we can start to see the association. And that's making these kind of common patterns of things that might make it more difficult, make the symptoms worse for people. We're individualizing that. So usually when people are in more stressful situations, the symptoms will get worse. But what's stressful for you might not be stressful for someone else. So I need to kind of check that out. And that often might bring up other areas like, social situations that they might be in, cause, really triggers off their depersonalisation, derealisation, and gives other clues, or that they've got kind of low mood that's also attributing, or anxiety or whatever. So that helps us to kind of see what areas we need to target. And in addition to that, I will also usually do a very typical kind of CBT vicious cycle maintenance formulation. That's all very jargony, but basically just finding a time. So if Alex, you'd give me a diary of, there were a couple of times where your symptoms were really bad, I'd map with you and literally map it out on paper. Let's have a look at one of these typical times where your symptoms get worse. And we'll look at what the trigger is, what symptoms you noticed. Crucially, at the center of it, what were the thoughts and what were the beliefs and attributions that were happening? And then what were your emotional responses, your behavioral responses, your physiological responses? And also I map out a sort of additional bit, which is your kind of thinking, sort of cognitive processes as well as cognitive content. So cognitive content, I'm actually thinking of, capturing the verbatim thoughts that might be going through your mind. But there might be other processes as well, such as, symptom monitoring or putting your attention on it, or particular kind of thinking biases that might be attached. So we would then map out a typical pattern. We may layer on another one that's a different situation, different trigger, so that we've got, sometimes just one, sometimes two or three that are overlapping each other. And really that is telling us, what do we need to start working on? And that usually leads into looking at your thoughts about these symptoms and what's happening about them. So often in the assessment, I may have asked people, when you first experienced these symptoms, what did you make of them? What did you think was happening to you? And some of those really very frightening beliefs may still be residual now. They might not be that residual. They might be really quite prominent still. I've damaged my brain in some way, or, I'm going crazy. Is this the beginning signs of schizophrenia? I'm never going to get over this. Sometimes people have gone on the internet, which is very helpful for information giving, but also you can read about people that have had this for long periods of time, and that can be very frightening for people to read about. Or they read that there's no treatment, and things like that. So there can be a lot of very frightening beliefs about the thoughts, or also how it might be affecting their functioning. So it might be other people can see this and they can see that I'm disconnected, or what other people are going to think of me, or a whole bunch of kind of cognition. So what I'm trying to do is extract those unhelpful beliefs about the depersonalisation, derealisation symptoms, and also then map out their responses to that, both, with maybe behaviourally. We're usually looking at different avoidances, or there might be things that they try and do that they think might be helping, but actually might be maintaining or making things potentially worse for them. So that's kind of where we would start in the treatment. And then moving on from that is, if I haven't done it already in the assessment, sometimes at the end of the assessment, we'll really look at what is depersonalisation, derealisation, what is the theory behind it, what is actually happening to people. And that's really helping people to see that this is dissociation generally, and depersonalisation, derealisation being two types of dissociation, are actually, an incredibly interesting and clever way that humans have of just taking themselves, removing themselves from a situation that feels really overwhelming and inescapable. So if you can't run away, you then can dissociate, and hence, that's why I was finding it in people with childhood trauma. They couldn't get up and leave home or get away from the trauma that they were experiencing. So they learnt to kind of psychologically remove themselves. I say learned in some cases, but sometimes it will spontaneously happen. Dissociation will just happen. It seems to be a really innate human mechanism to kind of just take ourselves away from the situation. So one thing that's really crucial in the treatment is for people to see that it's actually a kind of benign, trying to be helpful mechanism that has become, but if you don't know that, and most people don't when it first happens to them, you kind of get really frightened that you're, disconnected, or you're losing kind of parts of yourself. So it's really helping people to see, the sort of more psychological, theoretical perspective on dissociation. It's trying to help you. Your mind is trying to help you here, and therefore reducing the fear of these symptoms that have become a bit stuck. So often, when people lose the fear of the symptoms, they start to dissipate because they're not being maintained by anxiety. That's kind of like the fuel that's keeping them going.
And I think this lens is so useful to take for other mental health problems like depression and anxiety. I think you can make a strong argument in many cases that that's also your brain trying to help you. Like, at least sadness or some element of depression is, for example, helping you, taking yourself out of a stressful situation, maybe thinking about some losses you've had and why they're important to you. Anxiety is there really to help keep us safe and to avoid threats. Yes, anxiety can misfire and we can become anxious about things which aren't really posing danger to us. But the reason, like anxiety, sadness, anger, even, these things all exist for good reasons. And then, as you say, we can get into these vicious cycles where our reactions to them can make them worse and worse, and it can kind of spiral out of control.
Exactly. So that's what I'm sort of mapping with somebody in a sort of shared way. We're both as a team trying to, pinpoint, times where these symptoms are very prevalent and being triggered, to work out, well, what's happening in that scenario? How are you reacting to that, so that we can then start to dismantle those kind of feedback loops, and bit by bit stop that kind of snowballing effect, putting sort of, I'm mixing my metaphors here, but putting brakes on in different places so that these feedback loops aren't happening, so that we can start to create what we'd call a virtuous cycle where the symptoms may be triggered, but we kind of go, oh, okay, this is what's happening, what's going on, what's causing this to happen, and how can I change the situation in some way, or how can I change, what I'm thinking about the situation that will be more helpful to me. So, but there are certainly some people where the depersonalization and derealization has become quite a habit for them, and they may have had it for quite a long time. And so there are people where, so most people initially, there's quite a lot of stuff that's maintaining the depersonalization, anxiety, depression, all sorts of things. So I'm looking to see what is causing these symptoms, what's causing the dissociation, and then alleviating the causes that's keeping it going, also alleviating the anxiety about the depersonalization, derealization. And then if there's still residual symptoms, looking at this being a bit more of a kind of default habit that they've, developed as a way of kind of just sort of disengaging from, life. And sometimes that can be a little bit more of a kind of, a way of intellectualizing life, sort of standing back from it a bit. So sometimes it's become a little bit more of a sort of personality trait to kind of be a little bit more
detached.
Yeah, to be detached. So, in terms of the kind of treatment, I usually start with kind of CBT because there's usually a lot of mileage in that. But I may bring in, if the CBT on its own is not sufficient, I may bring in other ways of looking at things that are a bit more. So I would use something that's called schema therapy, which is a bit more looking at more or schemas or traits. And in schema therapy, it's in the kind of model itself, which is called the detached protector mode, which is basically describing, someone that's sort of detached as a form of protecting themselves from emotions.
And you said sometimes people can do things to try and help and to try and like decrease these experiences, but they end up maintaining them or making them worse. What are the common behaviors that people do which make things worse?
Number one would be avoidance.
Like avoidance of stress?
Yep. Or situations that trigger stress, so they may withdraw. So, I sometimes get people that have, just literally gone into their room for months. And some people, I'm working with a couple of people at the moment that have become completely agoraphobic. They just haven't gone out for years. And so, it's because they're frightened of the depersonalization, derealization being triggered. And that's what that is causing the agoraphobia, mixed with some, anxiety and panic, but it's more focused on those symptoms. But it can also be social situations, but also what in CBT terms is called safety-seeking behaviours, that people, as well as maybe avoiding things, may do things that they think, helps prevent the symptoms come. And so those, they can get kind of entangled with, doing certain things that actually they think helps prevent this or prevent it getting worse. And so we need to kind of test that out experimentally so that they gradually let go of that. So I do, like graded exposure and behavioral experiments so that they can test these beliefs out, test things out, and gradually start introducing things back again. Or alternatively, start dropping things that they've, props that they've got, starting, that they cling on to. So that's the kind of most common things in a kind of on the behavioral bit of the CBT.
I'm enjoying listening to your way of working. It's making me think about CBT generally as it applies to anxiety, depression, what have you. CBT, cognitive behavior therapy, includes talking about thought patterns, emotional patterns, behavior patterns. I feel like very often we miss perception, like how we see the world. So imagine someone who doesn't have derealisation, depersonalisation, they just have social anxiety, for example. I feel like a lot of times when we're treating people with social anxiety, say, we miss the fact that social anxiety isn't just a way of behaving or feeling or thinking. It's also a way of perceiving the world. So like an example I'll use commonly is someone with social anxiety will walk into a party, say, see a group of people laughing. They're much more likely to perceive that group of people to be laughing at them. That's their perception. That's kind of matching their psychological state. So I'm enjoying listening to talk about your way of working because obviously derealisation, depersonalization, those are perceptions. So you're forced to actually look at how is this person's psychology affecting the way they're perceiving the world. And I wish we did that more when it came to depression, when it came to anxiety and other conditions as well.
Well, it is there. I mean, as I say, I kind of will have with CBT, the way people map it out, they might do just a few different kind of boxes that you put things in. But I always include now, as I said earlier, a difference between the kind of cognitive content, as I call it, your kind of verbatim thoughts that you might have, but also these cognitive processes. So in the cognitive process section is stuff about kind of thinking biases and attentional biases, which is what you're talking about. You go into a room, where's your attention going? It's, and so with depersonalisation, derealisation, there's often a lot of kind of self-focused attention, very similar to kind of social anxiety. They'll be kind of really checking in with their symptoms all the time, or temperature taking. So you've got your little kind of depersonalisation, derealisation thermometer, metaphorical, that you're just, how is it now? And what's it like now? And just constantly checking your symptoms. And so, most people will kind of go, oh, yes, I do that a lot. And in checking it, you then become aware of it. You kind of then, catastrophizes, part of the thinking biases again. There's more thoughts. Oh my goodness, it's getting worse. Now people really are going to notice. I look weird. I look glazed over or whatever. And so it's a big part looking at the attentional and thinking biases part as well, because that's another area that you can target therapeutically.
And you said once people become aware of these patterns, and particularly once the fear of the experiences comes down, then it tends to dissipate. So is the prognosis quite good? Like if you get the right diagnosis and you engage with treatment prognostically, is it quite optimistic?
Yes. And ideally, the sooner that happens, the better.
Before it becomes entrenched.
Yeah. And the problem is, and I literally, yesterday, with a client, she was talking about how, unfortunately, going and speaking to people that didn't know very much about depersonalisation, derealisation, just left her feeling, oh my goodness, what is this? And, she was saying, like you would with a physical condition, if you go and seek help and you're surrounded by people that go, wow, I don't really know what this is or what we do, you would be, really getting quite worried. But the doctors don't know what this is or what they can do about it, and everyone seems a bit baffled and lost, and that really can just feed that anxiety. So, yeah, we really need to try and get help there. And we've tried to do it through a targeted sort of what it is and what you can do to help, targeted at GPs. And then we've got, Royal College of Psychiatry. We've got an online module about this. So really getting people to be able to know what it is, so that, and then, have some basics of what is helpful for people, so that very early on when people seek help, they can be reassured, we know what it is. There are treatments available, because there is still this kind of like, we don't really know what to do with it, which is a bit unacceptable now, because there is evidence that certainly antidepressants as well can be helpful for people, but also, talking therapies. And this, all I've done really is, apply the CBT templates to this condition. So, how my work might differ from general CBT is only that I'm putting all of this at the kind of heart of the CBT model. But people, can get help with their anxiety or depression that may then also alleviate their depersonalisation and derealisation as well.
Yes, and it sounds like there's a lot people can learn, even if they don't have a mental health condition, about just understanding your mental habits and patterns, understanding how they help you, but how that coping mechanism often serves to undermine our best interests. I feel like that's something I wish more people understood. Like we usually think of habits as behaviors, things I do over time. And I really wish people would understand that a way of thinking and feeling is also a habit. It's just one that kind of starts automatically as we go through life and get older. But it's also, and CBT reveals this, it's something we can have some authorship over. And often the things we think we're doing, which are going to help us, and they're often our most steadfast allies, we think, can be causing us to stagnate and stopping us from moving forward at times.
Yeah, I mean, I'd like ideally it to be the level of awareness so that people know what kind of dissociative phenomenon are before they experience them, because then you kind of go, oh, right, I know what this is. This is fascinating, really, as well as, I'm obviously in a difficult situation, but wow, this is what's happened. I know what it is, therefore I don't need to be frightened of it. Because they don't have that, people are often quite frightened of dissociative reactions. But for most people, they can be just transient and helpful.
What do you think has surprised you the most over your years learning about and working with this condition? Or what's the biggest thing you've changed your mind on?
That's an interesting question. I suppose what has I originally started thinking it was just all about trauma, and then being puzzled as to why are these people coming and seeing me and they don't seem to have any trauma. But I learned that quite quickly about, that it's not just trauma that causes this. But I suppose sort of as you get to see more people, there can be sort of other subgroups. And there are people as well where they would say that they don't feel very much anxiety. So this is a kind of newer realization in a way for me, is that there are people who, there's a sort of a perfectionistic or people with perfectionism subgroup. And that's the kind of pressure and the sense of being overwhelmed by their continual unrelenting demands on themselves that seem to be maintaining the depersonalization. They'll sometimes say, I don't really feel anxious, but wow, I do need to get on with all this stuff and it's really unrelenting and impossible to achieve. And so there's a sort of depersonalization that seems to be maintained from some people that have very, very high levels of expectations on themselves. And that I don't think has been really written about or it's in the sort of professional or public realm very much.
I've been thinking a lot about perfectionism and overachievers on the podcast. I've written a couple of essays about it. I didn't know that this was also something they could experience. Actually, very helpful for me to know that. Are there any online resources or books you would recommend if someone wanted to go deeper and learn more about depersonalization, derealization?
Yes, I would say it's very good to make contact with the charity. So myself and I was kind of part of it initially, set up a charity specifically for depersonalization, derealization. It's called Unreal, and now it's always been a grassroots charity, but it's now completely led and run by people with lived experience. So they are all extremely knowledgeable from not only their own experts by being experts by experience, but also, over the years they've got to know so many people with the condition. So it's a really helpful place to go and get information that's well resourced. But they run peer support groups as well. So it's worth checking in with them so that you don't feel a sense of, oh, I'm the only person that has experienced this. There's a community of people. And so people often describe that being very profound, something that has made them feel very isolated. Suddenly they're online and there's people all who know exactly what they're experiencing. So I think that's a really important resource. Myself and some other co-authors, there's an Overcoming Depersonalization and Feelings of Unreality book. It's a self-help CBT book. It's currently second edition. We're actually just about, to start working and updating that to do a third edition. So that's very helpful both for people that are experiencing it themselves, but also they're usually good resources for clinicians as well, because it will talk through some of the main techniques that you can use. It's being put in language for people that are not clinicians, but obviously clinicians can think, oh, okay, so these are the sort of techniques that we can use with people. And then, as I've mentioned, for psychiatrists, there is the online module through the Royal College of Psychiatrists that can be accessed as well.
Wonderful. I'll put some links to those in the description. Dr. Elaine Hunter, thank you so much for joining me. I felt I learned tons today, and I'm sure our listeners are going to get a lot from it as well.
Oh, thank you so much for giving me the opportunity to talk about it a bit more. And, as I say, always trying to raise awareness. But final message is there is hope. So don't feel despondent if you have these symptoms, because you can, and can get better from them.
Wonderful. Thank you so much.